traditional territory of the Woolstock-Wake. These territories are covered by treaties of peace and friendship of the Woolstock-Wake people, first signed with the British Crown in 1725. I call our meeting to order. Attendance has been taken? Yes? Approval of the agenda.
Motion to approve the agenda, Dave Morrison.
Second it, Malpel or Mucko.
Any discussion? Ready for the question? All those in favor?
Aye.
Motion carried. Are there any conflict of interest for disclosure this evening? That is no. Number 5, consent agenda. A, approval of minutes, October 1st, 2024, October 17th, 2024, October 24th, 2024. B, Regional Infrastructure Committee reports. 2, C, Community Development Committee report. D, Oversight Committee report. And I'll need a motion to adopt the consent agenda.
So move, Murray, Forsyth.
Second one, Bolton.
Any discussion? Ready for the question? All those in favor?
Aye.
Any? Motion carried. Thank you. Now we'll move on to presentations. Healthcare is important to us all, and the CRSC should use our influence to take a leadership role on this file. Dawn and I met with Dr. Russell in August to discuss her work and found it to be very interesting. To start the presentations, we will hear from Dr. Jennifer Russell, who is the Executive Director of the UNB Institute of Population Health. I'm sure everyone recalls the leadership Dr. Russell provided for our province during the pandemic. We are happy to hear from her tonight on aligning healthcare policy with regional needs and the need for collaboration. Welcome, Dr. Russell.
Thank you very much. I really appreciate you inviting me to come and present to people that I've met before. I see a lot of familiar faces, and welcome to the people that are online. When we met in the summer, I think it was really a good opening discussion around what the Institute of Population Health is supposed to do in our minds, and what we hope to achieve with a lot of collaboration. So if the slides are ready to go. So I renamed the presentation Thinking Outside the Box to address community needs for many reasons. One, you've had a transformation in terms of the responsibilities that you've been given, downloaded from the government at the provincial level to the municipal level. And that has presented a lot of challenges. And I'm doing a tour of all the regional service commissions. So I'm doing a listening tour, listening to what the biggest challenges are that you're facing, but also what things you have in common with other regional service commissions. I also happen to be doing a listening tour with the First Nations communities as well. So I hear common themes in First Nations communities as well as the regional service commissions. 2 of the regional service commissions that I met with recently said, you know, Dr. Russell, it's really great that you're talking about population health. It's wonderful. How does it help us? What does it mean to us? And if you have ideas and suggestions on how to make our communities healthier, we would love to hear from you. They said they had community assessment needs, they, you know, on different levels at different times, but it's never been necessarily always translated into action at the ground level, at the community level. So we can talk a little bit about that tonight. I'll go through a little bit of the things that we talked about this summer, and then we can open it up for discussion. I don't want this to be too formal. Please feel free to interrupt me at any time. I can talk all day and all night about this stuff. I eat, sleep, and breathe it. I started my medical career back in the military. I paid my way through med school starting in my 2nd year at Memorial University. So my obligatory service was spent in Ottawa. So I have a lot of thoughts about the military and occupational medicine. I have a lot of thoughts about my career after the military when I became a civilian working on the base and then off the base with Veterans Affairs. And then I worked for 6 years at the Methadone Clinic here with Dr. Heather Logan at Victoria Health Centre, Mental Health and Addictions. I also worked as a hospitalist in the hospital system. I also worked as a family doctor doing locums for family medicine for family doctors on that leave. I spent 10 years in government in public health because I was really interested in upstream prevention and trying to help people at the population level as opposed to one-on-one. What I realized in the Department of Health, in the branch, or I guess the Division of Public Health, was that most of the Department of Health and most of government is focused on health service delivery. That has nothing to do with making people healthier in the first place. And most of the levers and power and control of legislation and policies that can impact people's health in the long term don't actually fall within the Department of Health. So the thing that I'm able to do with the Institute of Population Health, now that I'm at UNB, is I can work with academia, I can work with researchers. We can figure out what research has already been done or can be done. How do you get that translated into action, into policy, legislation, and programming? How do we report on population health outcomes, and what can we do with that information? So next slide. So tonight I was just gonna talk a little bit about what the Institute has been up to since we started last December and where we're hopefully headed. The next slide. A beautiful city. That I actually want to speak to this slide. So I just got back from Copenhagen with a researcher named Trevor Hansen, who is at the Department of Engineering at UNB. And there were 4 teams from across Canada that went to this Healthy Cities workshop in Copenhagen. One from Burnaby, one from Toronto, one from Montreal, and one from St. John. And I was really, really pleased to be asked to be part of that team. Each team was made up of somebody from public health, a counselor or a mayor, a traffic engineer, a city planner, and a researcher. So 4 teams made up of exactly the same complement of people. The team from Toronto actually had Dr. Eileen de Villa, who was the Chief Medical Officer of Health for Toronto. And I had a lot of respect for her. So it was a great meeting of minds to learn what happened in Copenhagen to make it go from a car-centric city to a people-centric city over the last 30 years. 30 years ago, Copenhagen was on the verge of bankruptcy. They decided to sell off a bunch of land, and they took that money and turned it into investments in infrastructure with policy and legislation to make the city healthier. So I was immersed for a whole week in what does that look like and feel like, and what did it translate into in terms of the health outcomes of the population when only 25% of people are driving cars to and from work and school? What does that do to the carbon footprint? And it was really impressive and really eye-opening. Certainly for the public health people in the room, when we were learning about all the things that had happened, we weren't surprised or shocked. But to see the reaction of the other people who were on the teams, the traffic engineers, the researchers, the city planners, and the counselors and mayors, it was really eye-opening and really, I guess, refreshing and energizing to see what the possibilities and potentials are when we focus on things to make people healthier that have nothing to do with the healthcare system. Next slide. So we know the health system is at a crisis. We knew this before the pandemic. The pandemic highlighted that fact. And when we were trying to flatten the curve for COVID, all of those messages and all of those policies and all of that legislation was really at all levels of government and also all governmental departments. They all had a mandate to flatten the curve. They all had money to flatten the curve. They all had resources to flatten the curve. And we had a way to measure whether the curve was being flattened and what that did to the healthcare system in terms of freeing up accessibility. As you know, at the beginning of the pandemic, people stayed away from the hospitals because they were terrified. But once things got rolling in the pandemic and people were more comfortable in the healthcare system, access was a problem if there were outbreaks, as you know. And so any policy, every piece of legislation, anything that could be done to flatten that curve, to protect the healthcare system was done. And I feel like we did succeed. And I feel like we did protect the healthcare system as best we could, but it's still kind of limping at the moment, as you know. And if you're connected with the healthcare system in any way, shape, or form, the healthcare workforce feels it, as well as the people that are trying to use the system. So when I talk about the things that impact the healthcare system and health that don't have anything to do with the healthcare system, I'm talking about population health. And I have conversations with people like yourself, but I also am having conversations and meetings with the regional health authorities, Margaret Melanson and Pastor Rosier, who I worked with during the pandemic. And they're also keen to be very encouraging and aligned with anything outside the healthcare system that helps make people healthier and also keeps them from needing to access the healthcare system and taking the pressure off, whether it's aging in place and keeping people out of long-term care facilities, which means that those people that are waiting for beds in a long-term care facility who are in the hospital system and taking up ALC beds. Again, it's a trickle-down effect. So anywhere along the system that we can see improvements that take that pressure off, they're very interested in that. And the Institute of Population Health can help with those types of things. Next slide. So, and because I'm in academia now and I've had quite an eye-opening experience with working with researchers, they're all very keen to keep doing research and they're doing great work. They're also keen to see that research translated into action, which you don't often see. Most times the research grants and research proposals are done, the research is done, they present it, and then it sits on a shelf and collects dust. And a lot of researchers come to me and ask me why. Why is it that research doesn't get scaled up? And I can tell you why, because I worked in government for 10 years and I understand the budget system, I understand the budget cycle, I understand the pressures and where, if you're gonna pay for one thing, it has to come out of something else. It's a finite amount of money. There's no extra money floating around in the system. And so those types of decisions are made very judiciously, very, with a lot of scrutiny, and it's a challenge. So nobody has the right answers. Nobody's gotten it right thus far. There's a lot of smart people trying to make it work and trying to get it right. So I have a lot of respect for the people that I have worked with in government and continue to collaborate with, and I have a lot of respect for the people working in the healthcare system and my colleagues. I do happen to wear another hat. I'm also the president of the New Brunswick chapter of the Canadian College of Family Physicians. Not because I'm a practicing family physician anymore. I hung up my stethoscope 10 years ago, but there was nobody else who wanted this job. So they approached me and said, look, all the family doctors are burnt out and tired. Can you please take on this 2-year role and help advocate for working conditions and the working environment for family physicians in this province and helping with recruitment and retention. So I did say yes. So I do work part-time with that hat on, and I work closely with the Medical Society on that. And so I'm happy to see my colleagues here from the Medical Education Foundation. Next slide. Next slide. Oh, there's a slide missing. Maybe another slide. Keep going. There. So I actually got my son to build an origami pyramid for me tonight. I was going to bring it and I forgot it. And so what this is about, this slide is about what things are affecting our health. And at the top of that pyramid are all the one-on-one care. Anything that is really close to that pointy tip are very labor intensive and financially very costly. And they don't always have better outcomes. We're treating people at that level who already have a disease. If you get into the middle part of the pyramid, you're looking at secondary prevention, which is screening. So breast cancer screening, prostate cancer screening, colon cancer screening, cervical cancer screening, and those are very valuable and very important. But again, you're catching people who already have a disease. You're slowing down the progression, and you're catching it and preventing it from causing mortality and morbidity. And my colleagues here from the Medical Education Foundation are working at the top end because it is all primary, secondary, and tertiary prevention are all important, and we need to work on all of them continuously. The part at the bottom that gets ignored for the most part are the socioeconomic factors, legislation and policy. Those things have the biggest impact on population health outcomes, and they're probably given the least attention because the crisis at the peak at the top is what's always demanding our attention. So each one is important. I feel like if we focus more on the socioeconomic factors and policy and legislation, we can really help at the top end. And when you think about seatbelt laws, when you think about tobacco laws, seatbelt laws in one fell swoop, 99% drop in ejections and people dying from ejections from car accidents overnight. That impacted the entire population. Tobacco laws decreased smoking rates. We do know that it took probably 30 years, but I was driven to school in a car with my mom smoking cigarettes, and the teacher smoked in the school in the classroom. And today those things don't happen. And when I was driving my children around when they were younger, I remember one day one of my kids saying, "Mommy, it's so sad that our babysitter Kathy smokes because she's going to die of cancer." And then he said, "This is my son Zach." He said, "And where do you buy cigarettes? I've never actually seen a store that sells cigarettes." So there's a lot of things about policy and legislation that impact behavior, impact culture. And we saw it during the pandemic. We put a policy in place for masks. We put a policy in place for 6 feet distancing. It changed people's behavior and it changed the outcomes of what we were trying to achieve. Next slide. Next slide. Next slide. So in terms of research priorities, the Institute is a hybrid organization. So we have the research side. I just hired my scientific director, Dr. Emily Richard, this summer in July. She is the Associate Dean of Nursing at UNB Moncton. She has a background in kinesiology and in nursing. She is very interested in workforce health. She's very interested in seniors health and rehab. She has a lot of experience, and I'm really happy that she's on our team now. And the other side of this organization is really about knowledge translation. It's about reporting on population health outcomes, which are not really reported on too robustly right now. It's also doing analysis and recommendations on policies, legislation, and programming and research that should and could be scaled up. And then hopefully, if everything goes well, it would be fed into government strategies at the provincial level. Ideally, next slide. Next slide. Next slide. Actually, go back one slide. So when I talk about viewing reports, so this is the kind of thing that I'm hoping that we will start to do. We're only 1 year into our mandate right now, and our mandate is to improve population health outcomes in the province of New Brunswick. And we want to do it through collaboration, and we want to do it through research, and we want to do it through analysis and recommendations and knowledge translation. So I can talk till the cows come home about all the research that I know about any type of population health issue, whether it's obesity, whether it's diabetes, whether it's exercise, whether it's dementia. But if that knowledge is not translated to the people that really need to hear the messaging around that, we're not really going to succeed. And so some of our work is going to be around knowledge translation for different audiences. It's also about interdisciplinary work. So that trip to Copenhagen, again, it was eye-opening for me to see the collaborative work that can be done with different sectors and different departments and different organizations. So we want to keep that interdisciplinary a collaborative approach in mind when we're doing the work that we're doing. And that research was funded by an organization called CIHR, and they did it deliberately. So the head of the Population Health Institute of that organization deliberately handpicked those types of people to be at that conference because they knew about that intersectoral type of work that's really important interdisciplinary work. So that's definitely going to be front and center in the work that I do at the Institute. The other thing that happens when you're on a university campus is you get to meet all the different faculties and all the different students. And I have access to graduate students, undergraduate students. And because of the work with DalMed NB, so the medical school down in St. John, I also have connections to the researchers down there. So tomorrow and the next day, I'll be attending the Healthy Seniors Pilot Project Symposium. And this is 5 years worth of research that was done, and they're presenting all the findings of that 5 years worth of research. And because of my collaboration with these different groups, I get to tap into what they've found and how can we connect and how can we use that information moving forward together. I also spent some time in the last couple of weeks at the J. Herbert Smith organization at UNB. You might have heard of Dr. Dhirendra Shukla. He won a Rotary Award in the last year and other awards, and he's very innovative in the type of work that he does at UNB, including collaborating with Harvard. So connections were made at this event, and other connections get made. So there's a lot of exchanging of information and connections and knowledge that we're going to keep building on. Next slide. So I'm really not here with an ask. I'm really here to listen. I'm also here to answer questions. And after my listening tour, some people have asked me, are you going to fill us in on what you heard and what you're taking back in terms of what you want to do next? And I definitely will circle back when I'm finished my rounds of all the organizations and find out more about what we can do to move forward. And there might not be any more after that. Oh, okay. So yeah, so those are some of the things that local governments are interested in talking about, but there's other things like homelessness and mental health and addictions and those are some of the other topics. And another slide. So we have our flattening the curve. This is the other thing I talk about with all my audiences, and that is flattening the curve of health service needs. Utilitarian has projections of health service needs between now and 2050. I am trying to develop some modeling that shows if you put policy X or policy Y or legislation X or legislation Y or program X into place, we can flatten the curve of health service needs between now and 2050. I feel like it's language that people can understand and they can wrap their head around it, and the whole all of government approach can also be used in that way, or all of New Brunswick approach to flatten that curve. And anyway, that's one of the projects that I'm working on. Next slide. This must be, is this all the reasons for the commission? I can't see what that is.
Sorry.
Oh, this is your reason. Ah, okay. So, okay, and another slide, next slide. Okay. So I got 20 minutes to answer questions.
I think we'll start with Director Feedwell. Do you have any comments or questions?
No, I thank you for the presentation and coming out and talking to us tonight. Certainly, it's something that's of utmost importance in my region and everybody else's as we see we've recently lost one doctor in Arcadia, and we're trying to figure out how we accommodate for that. And in particular, looking for some legislative changes in particular around nurse practitioners. So I wouldn't mind hearing your thoughts around that.
Thoughts about recruiting nurse practitioners?
Well, and perhaps how nurse practitioners are engaged within the healthcare profession around New Brunswick, and perhaps widening their utility in the system.
Yeah,
That might be loaded, but it's appropriate for me right now.
I'm not even sure if we have enough nurse practitioners. I feel like we have, the ones that we do have are being utilized. I don't think there's any nurse practitioners out of work right now. So I could be wrong, but my understanding is that I think they're being fully utilized right now. So it would be a matter of recruiting more alongside more family physicians, which we also are short of.
Yeah.
So I'm not sure that there's legislative changes that need to happen for that.
Okay.
I could be wrong though.
I understand.
I know the new government has a plan to put 30 new clinics in place that are multidisciplinary.
Yes, and particularly in that context, I think that's important, because being paired with a medical doctor I know is important for a nurse practitioner. I believe, from what I'm understanding in my engagements, that there's some challenges around some legislation, and of course I'm only speaking from sitting in meetings, so I don't have all the details.
Sorry, I'm not aware of that. So,
Okay.
And I know the medical society is working. I feel like the medical society is going to be moving forward with helping with some of these things. So
Yes.
I can't speak to that.
No worries. I think we have a summit coming up next week, actually, so we'll hear some more there probably.
Okay, thank you. Director Fox.
Nothing for me. Thanks for the presentation.
Okay, and now we're gonna start here and go around the table.
Nothing for me, there's nothing.
Okay, Director Corey?
No question, I guess just comment that in our community, we're sensing that after COVID time, maybe the 5-year window, and the housing changes, the great cost increases in food and other areas they're impacting our families on the socioeconomic side now, but seeing that the real bump is probably 2 years out, when the resources are used up and there's no place to go. And that is impacting communities now through the increased drug use, increased more problems with children at school and that sort of thing. So from a health point of view, I think that is one of, for smaller communities, that is one of our biggest concerns. Even if we had the practitioners, we still have issues that would be beyond their ability to. So,
Housing is definitely a common theme that I'm hearing. I did speak to Brad Henderson and St. Andrews about some of the things that they were doing. In 2021, I had visited, because back then there was a vaccine clinic going on, and I was kind of doing a little bit of a tour with visiting people at vaccine clinics, but vaccination clinics, but he was talking about the shortage of housing back then in 2021, and it was impacting their ability to house people who needed to work in the different businesses in St. Andrews. So they ended up doing, the Regional Service Commission ended up giving an economic development grant to a private developer to build 2 affordable housing buildings. And when I heard about the success of this, I was thinking, okay, how can this be linked to other communities in terms of sharing that knowledge and sharing that information and sharing that approach? So I think that is one thing that's going to come out of me having gone around the province and listened and heard these type of concerns. But you're right, because the housing piece does play into the other pieces. Absolutely.
Thank you.
Thank you, Madam Chair. Thank you, Dr. Russell, for your presentation. I think about these things a lot. My graduate student work was at UMB at the Chronic Illness Research Institute, where we did social determinative health connections to policy. So I think you actually undersold how difficult it is to get municipalities and government to invest in the base of that pyramid that you had on your slide. For example, the trail system in Fredericton, it doesn't exist because the municipal council thought it was in the best interest of everyone's health and well-crafted lifestyles. The municipality was sued by private citizens, who demanded that the trail system as an element of public property was kept in the public domain instead of given to the adjacent landowners. And then the city had to figure out what to do with it. Then they found these arguments persuasive and realized that part of our mandate is providing the infrastructure that people can use for recreation, which is a component of a healthy, well-crafted lifestyle, so on and so forth. So it's funny how these things happen, but I think these stories, if you can dig into them, will provide you some guidance on how to move forward. And part of the lesson that I've learned from this is that it's important to ask your strategic partners in any area where you're collaborating to really make sure that they can bring their strong suit to the table. And the strong suit from the municipal sector, might be a little bit of money for scholarships, but really it's around long-term planning and doing things like housing. So one of the things that I'd like to suggest that the municipal sector look at, and I'll see if I can't get the new government to hear me on this, is to add managed care facilities to the typology of housing that we see as required elements of our communities. Because I can't see the municipal sector doing anything more valuable than producing a lot of supportive housing to get the bed blockers out of the hospital system right now. We can do that a lot quicker than anyone else, especially with provincial and federal support. But we really need to identify that as an element that's in our strong suit. And I know a lot of communities have gone out of their way to do this. Ormond is a great example. And I think those are the kind of things that we need to do. So maybe add that to the things that you've listened to. And see if we can't get some ears to tune into that at higher levels of government, because we will need support federally and provincially to kind of make that come true.
Well, I'm glad to see that there's a minister of housing.
Yeah.
So that somebody can focus on that portfolio to the exclusion of everything else. And I know that social development is really understanding all of those needs as well. And they understand the implications for long-term care, and they understand how that backs up into the healthcare system. So you're getting more and more people understanding that. And when you said undersell, you're right. I didn't paint a very terrible picture of that. And maybe I'm overcompensating for what I know is really a big challenge. And in places like Australia and New Zealand, they actually have accountability and budget frameworks for well-being outcomes. So that means somebody's actually responsible for making sure people are healthy. Not that they have access to health care, because that actually doesn't make us healthier. That just means that when we're sick, we have care. But if you want to make people healthier in the first place and nobody's responsible for that, then it's nobody's problem. Like, I'm not paying for that. Why should I pay? That's not my responsibility. So back when I worked in government, if you wanted something done in DTI and Department of Transportation that was going to make people healthier, like wider sidewalks or more lighting, and we'd say, DTI, could you please do that? Because we know it's going to impact the health of the population. And DTI was, not my mandate. My mandate is to pave roads and to make sure that the infrastructure is there. Nothing in my mandate says that I have to make it so that it's healthy. And if you make me make it healthier, it's going to cost more money. And guess what? I don't have more money. So go pound sand. And so that really is what we're up against in what my whole time that I was in government. But because of the pandemic and because of the role that I have now, and I've had time to think about this and look at what is done elsewhere, I can take that information from places where it is working. So Wales, Scotland, Finland, New Zealand, Australia, and there's one I'm missing, have these budget and accountability frameworks for well-being outcomes with a budget, with accountability, with a way to measure it, with a mandate. And so it is everybody's responsibility because they all have money to make it their responsibility, and they all have the resources, just like in the pandemic. Just like in the pandemic, when we said, well, we're gonna have to do this policy and we're gonna reduce the numbers of COVID by this much, and education says, well, we can't do that because it's gonna be blah, blah. Okay, well, here's some money and you can do that now. And JPS would say, we can't do that because people would be riding the streets and we don't have enough police. Okay, well, we're gonna do it this way because of that. So there's conversations around, okay, well, if this is the common goal and this is the common outcome, how can every single department get on board with money and a mandate and accountability and a way to measure it? And then continuously monitor that to see if it's working or not working, if you're improving those outcomes. So ultimately, that is my goal, and my hope. And so the conversations that I'm having with each group of people helps, frame that and massage the messaging a little bit better and a little bit more, so that eventually, hopefully, I'll get into the right rooms with the right people and they will think, yes, that's brilliant. Yes, here's exactly what you want to do. And, I've got about 5 years to work on this. I'd love for it to happen before then, but anyway, that's my vision and that's my hope.
Okay, next. No?
No, and I'm good. Thank you, Madam Chair, and thank you, Dr. Russell. That was a very interesting presentation.
Thank
Appreciate
you.
your taking your time and your schedule to appear.
Thank you.
Next.
I do have something.
You're allowed.
Yeah, okay.
2 minutes.
Okay, well, I appreciate your comments and what you've done, and I was just wondering on the pyramid, is that pyramid scalable to urban to rural?
Yeah.
It is?
Absolutely.
Okay, cause I don't see some of those effects in my community, and it might be just a closet problem. And we have issues currently with the fact that we have one doctor probably sees 2,000 of my population, and he's 84.
Mhm.
And that's not a problem because he's a great doctor, but it is a problem because he's 84.
Yeah.
And so we don't really have 5 years of research, so I'm wondering when does, how
Oh,
does.
I'm not saying I want to do it. I want to do it way sooner than
I,
5 years.
I understand, but I was just saying, how does the research, at what point does it translate into budget awareness so that we can make differences today?
Well, I'm working on that modeling that I showed you, flattening the curve. So the sooner I get that modeling done, that is what I'll be presenting to government to say, if you want to make a difference, this is what needs to happen. You can, and the person that I'm working, the organization that I'm working with to do that, it'll almost be like a dashboard. If you can play with it, like, oh, let's dial up this policy, let's dial down this policy and see what it does to that curve.
So from a rural standpoint, I can tell you that we are not involved with our health clinics, at how they're administered, who comes, what, any of that. But if you ever need any help, from a rural area, give me a call. I'll be there to help you.
Thank you very
All
much.
right.
Very nice. Thank you. Next.
I'm good. I'm good. Thank you, Dr. Russell.
Thank you.
As well, very good presentation.
Thank you.
I think, 2/3 of the population, the parents now are still acting like kids. They want the education system to feed them. They don't know if the kids started to be sick or they let them go out and play. They don't take care of them and they don't know anything about it themselves, and they're backing up, taking them to the emergency room for little things that they should have been taught down the road. I don't know where it went, but
Mhm.
then it's backing everything up. And of course, they'd rather have them go to school and eat food at the schools, but what do? They'll take them to McDonald's as soon as they get home, right? They don't even feed them right. So I think 2/3 of the population have parents who are in that boat. And it's a downhill slide, and it's gonna work harder, that you gotta work into that, so.
Well, I'm glad you brought that up for a couple of reasons. One, data is really important when we tell our story. So one of the institutes at UNB that exists right now is called NDIRDT, which is the Institute of Data Research and Technology. And it's headed up by Dr. Ted McDonald. And they house a lot of data, and they have the ability to tie that data to people's medical records as well. So they can paint a picture of the province in terms of exactly what you're saying, what people are eating, how they're eating. They actually have the ability to map different diseases, different risk factors for diseases. So they've actually mapped all the risk factors for dementia in the province. You can see in the province where people have those risk factors and are more at risk of getting dementia or less at risk of getting dementia and then needing nursing home care. They've also mapped food insecurity around the province. So we can tell you all the places in New Brunswick that have food insecurity. And it doesn't just mean that they don't have enough food to eat, but it also means that they don't have the right nutritious kinds of food to eat. And there's a link between that and heart disease and high blood pressure, believe it or not. And so you can see, well, if there's more food insecurity here, there's more heart disease here. If there's less food insecurity here, so what are the types of policies and legislation and program that should be in place to address those things? So thank you for bringing that up, because data is really, really important to get the message, to get the story told correctly and accurately.
And they're still not getting enough sleep because they're playing the games or whatever. Well, another question is, what do you think of the mystery disease that's in the problem?
Well, what do you think of the mystery disease?
Well, I think it's probably on the northeastern side, more than down here, but, I don't wanna get it.
So you think there is a disease?
Well, there's people dying with strange things and that we've never seen before, so there's something there somewhere.
Aliens. Aliens.
Well,
Well, I know that the new government is planning to do an inquiry and look at it. So I had participated in a lot of the research and all of the inquiries like leading up to this. So I have a lot of knowledge and information, but most of it's been published on the internet, on the GNB website, and in the media. They don't always refer to the actual reports that we produced, that were also endorsed by, I think, 8 independent neurologists here in New Brunswick, as well as endorsed by Public Health Agency of Canada. So if you really want to learn what it is that we found so far, it is on the GNB website. And as I said, it's been endorsed by 8 independent neurologists as well as Public Health Agency of Canada. But the new government is planning to revisit that and make sure that no stone is left unturned, and people can feel confident and secure in the knowledge that there is actually no neurological condition. That's the findings that we did find, that there was no linkages between the people that had these different symptoms, that they all had an actual diagnosis separate from something that was linking them all together. So whether that was through autopsies or other results of tests or things that didn't get done or that got done later or what have you, so they all had an alternative diagnosis. None of them had something linking them together, but that's all in the report on the GNB website. And I know Premier Holt is going to be addressing it as well.
right, one other question, are you still singing?
I am.
Oh, good.
Yeah.
He's a great singer, by the way.
Thank you.
Next.
Okay. I'm very fortunate, our community of about 700, we have 3 doctors. So we're very, very fortunate. The problem that I see out there is aging population. How far behind the 8 ball does that put this research project?
I will not say who said this, but somebody called it a tsunami. So, it's not good.
No.
It's not good. No, so we do have some work to do, but the good news is that there are some solutions that people aren't even aware of that have been proven. It's about communicating them and scaling them up, in whatever way, shape, and form we can.
Thank you very much.
So I will tell you an interesting story, and I think I've already related to you. I was out to the FCM in Calgary back in June, and Director Powell, you were there. Well, I was booked for a tour the next day. Mind you, I didn't get into 2 in the morning and a couple hours sleep, and it was a 3-hour tour. I said, okay, get up. I went, registered. It was on electric scooters or e-bikes. And I said, okay, I'll take the electric scooter. So 3 hours, we toured the city, and they are really big on getting everybody outside. There was little parks, every bit of land that they had was transferred into parks for the people to enjoy. And one interesting fact was in the wintertime, they would clear the snow off the trails and stay before the streets so the people could use the trails to get to work. So, and they really encourage the outdoors. I thought that was quite interesting. So, nothing further? On behalf of the directors here and our staff, I'd like to thank you for coming in tonight and doing the presentation and taking questions.
Thank you.
And we got 1 minute to spare.
Give us a song.
Now we'll move on This evening, we also have a presentation from Alicia Long and David Ryan from the New Brunswick Medical Education Foundation. Alicia is the executive director and David is the fundraising manager. They're here to educate us on their programs and how we can get involved. Our CAO and economic coordinator have already met with Alicia and David to open communications and coordinate efforts. There is a health summit hosted by the Freyden Chamber of Commerce in partnership with NBMEF on Tuesday, November the 12th from 8 a.m. to 12 p.m. There are still spots available and this will be a very informative session. So the topic tonight that will be discussed is New Brunswick Medical Education Foundation. Welcome.
Thank you so much, Madam Chair, Mr. Smith, esteemed directors. It is a pleasure to be here this evening. I know Mayor Powell is very familiar with the presentation I'm about to give, so I'll try not to make it too repetitive for you.
I don't even remember more after the second time.
Normally I start this presentation off with a comment that it's a rare thing to hear a good news story in the healthcare sector. And while I believe that's true, I can't say it with Dr. Russell also being on the agenda tonight because the research that she and her institute are doing is remarkable. And David and I were just saying there are such strong ties. And both at the core, I think what we do at the foundation and the research that's going on, it's all tied to sustainability, better health outcomes for all New Brunswickers. So tonight I'm here to introduce the New Brunswick Medical Education Foundation, which is dedicated to enhancing access to healthcare for all New Brunswickers, for all New Brunswick citizens. And that's why we're here this evening is because Fredericton and the greater Fredericton region is among the hardest hit area in the province when it comes to access for care. The greatest number of unattached patients reside in this area in the entire province. And as many of you are familiar, that number, that 180,000 New Brunswickers who are waiting for a primary care provider is the highest it's ever been. And the fact is we actually have a solution or a partial solution to this. The New Brunswick Medical Education Foundation has established the most high-yield, cost-effective physician recruitment program that the province has ever seen. And that's what I'm here to tell you about tonight. If we could move to the next slide. So before I begin and dive into our results, I want to tell you a little bit about our origin story. And it's a really good origin story. So back in 2010, Dr. Donald Craig, a family physician based in the St. John area, had been in practice for about 40 years. And as he approached his retirement, he became increasingly concerned about the 3,000 plus patients in his practice and what would happen to them when he retired. First of all, he saw that the physician population was aging. He saw that there weren't this incoming population of young doctors. And finally, he saw that the doctors who were coming into New Brunswick weren't taking on 3,000 patients anymore. They might be taking on 1,000 patients or fewer. So at the time, Dalhousie Medicine New Brunswick was about to open its doors. So he approached the university and said, what if rather than engaging physicians out of province and trying to entice them back to New Brunswick, what if we instead dedicated time and resources to medical students? What if we developed a return to service scholarship model for medical students who are studying at Dalhousie Medicine New Brunswick or other medical schools and said, in exchange for this tuition relief, you pledge years of service to New Brunswick when you're qualified. The university said, great idea, we love it, but you have to take it on. We don't have the resources. So he did. And in addition to running his own practice, he founded what became the New Brunswick Medical Education Foundation. If we could advance. And as you can see, we already talked a little bit about the dire need, and I thought the tsunami language was so appropriate. We have one of our board members who routinely calls it, it's not a fire, it's an inferno. And that's really what we're all dealing with on a daily basis. But in addition to those 180,000 plus who are waiting for a family doctor, we also know that the provincial physician on average is over 49 years old. Within the next 10 to 15 years, we are going to see a mass exodus from the labor market. So how do we prepare? How do we ensure that there's not just the incoming physicians to meet the current need, which sits at about 390 vacancies today, but how do we ensure there's a pipeline in place to come in and replace the physicians who are going to exit, like the 84-year-old physician who has a panel of 3,000 patients. So our model is simple yet effective. We raise funds as a registered charity to extend scholarships and fund current New Brunswick medical students. What this allows us to create is a deliverable and a very powerful one, a pipeline of world-class qualified incoming physicians. And more than that, these are physicians at the inception of their career. So they have decades of service ahead of them beyond the few years we secured just through these return to service scholarships. And the results have been very impressive. Since inception, we have supported 318 students through 723 return to service scholarships. That's 723 pledged years of service for New Brunswick and New Brunswickers, but more than that, 723 years of care for hundreds of thousands of New Brunswickers who will receive treatment through these professionals. We awarded just this year 149 return to service scholarships totaling $1.1 million in tuition relief. All of these funds are paid directly to the students' universities, applied directly to their student accounts. So this makes us one of the largest scholarship programs in the entire country, and that's something we're very proud of. We currently have 57 graduate physicians who are now practicing across New Brunswick in every health zone, including 8 within the Fredericton City region. But what's even more exciting is our pipeline is currently comprised of 226 students. These are medical students and medical residents who have pledged to practice here once qualified. We could advance. And just to get to know our students, who are incredible people, one of my greatest pleasures every year is reading through the student applications. And one of the questions we ask each applicant is, why do you want to practice in New Brunswick? And the answer in almost every case is because it's home, because my family is here, because I've worked here, I volunteer here, I want to build a purposeful life here, I want my practice here, and I want to give back and be of service. So these are the students that we are supporting. These are the future physicians who are not only going to come back and practice medicine, but in so many cases, they turn out to be leaders. Like Dr. Russell, who volunteers with the College of Family Physicians in Canada and advocates for better work-life balance. So things like that. These are the leaders and wonderful people that we secure for New Brunswick communities. And the diversity is wonderful too, because we know diversity helps make us stronger as communities. So right now in our current recipients, the 144, we have 64% whom are bilingual, 45% are from historically marginalized groups. We know that our recipients represent 47 different New Brunswick communities, and we have the capacity in 2024 to support 75% of those students who applied for funding. You'll hear from me in a few minutes that our goal is to grow the foundation to a point where we can support every eligible medical student who is willing to commit to New Brunswick, if we could advance. And it's more than just numbers and tuition relief. There's actually a business case that supports this model as well. In 2023, we commissioned an economic impact report by David Campbell and GPA Consultants, where we asked the question, what is the value? How do we quantify the role that a single family physician plays in a community in New Brunswick? And they actually answered that question, and the results were staggering. Within 10 years of a family physician being in practice in a community like Fredericton or New Maryland or Fredericton Junction, they will generate roughly $2.85 million towards provincial GDP, $130,000 towards municipal tax revenue, $1.2 million in induced household spending. They will on average create 3.2 full-time equivalent positions. And finally, over that time, they'll see an average of about 8,000 patients. So when we actually shared these results with the physicians on our board, you could tell it was meaningful. The eyes lit up because nobody had ever quantified their value before. Nobody had ever ascribed a value or validated the work that they do day in and day out. So we know that these numbers are powerful. They're numbers that we brought to corporations, to government, and to municipalities to really clearly define the return on investment for those who do partner with us and who do create scholarships. We could advance. So beyond the numbers, beyond the quantitative data, we also illustrate the qualitative value and the service that we believe we provide to all New Brunswickers. First of all, we support succession planning. So if a physician who's looking at retiring in the next 4 or 5 years, they have the option to call us and say, you know, I'm from, let's say, again, New Maryland or Harvey, you know, and I'm looking at retiring. Do you have anybody in your pipeline who I can talk to? Anybody who's from this region or maybe interested in coming back? And that's a service that, you know, very few have been able to leverage in the past. So we've actually had physicians make the call. We're working right now on 2 opportunities in the Florenceville region where we can hopefully connect the physicians there with our alumni. We also work to connect future doctors to communities. About half of our scholarships right now are tied to regional return of service commitments as compared to provincial return of service commitments. So these are either municipalities, corporations, or entities like the regional service commissions who say, we'll support a scholarship, but we want that student to return to Miramichi or Tantramar or Strait Shores or St. John. And so we have agreements where we actually use those 4 years that the student is in medical school to help build that relationship with the community where that student has pledged to go, to ensure the best chance that that student will stay and that that community can retain the physician. We maintain robust communication networks with our students and alumni. So a student that doesn't come through our program, we provide them tuition relief and then that's it. Throughout their time with us as a member of their community, we provide monthly newsletters, an annual scholarship gala, robust social media communications, and beyond that, once they've graduated medical school, we track them and we stay in touch and we ensure that we know not only when they're finished their residency positions and where they go, but where they stay, where they move. And so we have a resource dedicated primarily to our maintaining our student and alumni relations file. And then finally, like I mentioned, we have a growth plan to support all New Brunswick students. Because while 75% is a wonderful target, wouldn't it be amazing if we could support every student who's willing to commit to New Brunswick? So we're calling this campaign Doctors for NB, and hopefully that's a phrase that you hear more and more often as time goes on, if we could advance. So again, the big picture, why do we want to bring doctors to communities? First and foremost, they provide families and communities with access to care and peace of mind. Secondly, we know that employers stand a better chance of growing their workforces when there is reliable, timely access to care. We've had conversations with regional service commissions across the province, and time again, we've heard that the number one issue brought to mind in any conversation, whether it's immigration, business attraction, business development, comes down to, can my employees have access to healthcare? How do we get them a doctor? How do we attract these newcomers and get them to stay? You need to get them a doctor. So we know that there's a clear connection here. We know that, as Dr. Russell alluded to, that our system is under stress. By bringing in more physicians, by bringing in more boots on the ground, we can alleviate the strain that's on our current physicians, our current nurse practitioners, and other allied healthcare professionals. And then we know overall that when we have a healthy healthcare system, our province is better positioned for growth. We could advance. So like I mentioned, we are fortunate to work with many donors, and the wonderful thing about this foundation is that it helps all New Brunswickers, regardless of demographic factors. So while the direct beneficiaries are students, whether in medical school or other allied healthcare professions, the long-term beneficiaries are the people that they help throughout their careers. And for that reason, there's an appeal here, not just from corporations or private donors, but also from government, municipalities, and the provincial government. And that's, again, why we're here, because I feel that everybody here has a voice in this conversation, and I would love to hear it once we do get to questions. This is the testimonial from Mayor LaPierre, who does have a scholarship with us and supported a lovely physician, Sebastian LeBlanc, who attended the University of Sherbrooke for 4 years. He's bilingual, he is from Dieppe. He's now attending his residency at the Moncton Hospital and plans to open his family practice in Dieppe upon graduation. And then if we could advance. And then just to illustrate the needs of the students again, we've talked about cost of living going up. We've talked about the cost of food going up. This quote came from one of our applications for a scholarship this year, and it really struck with me. This was a second-year medical student at the time. He's now in third year, and he's an aspiring pediatrician. So he is an incredible volunteer, an athlete, leader, but he went from his undergraduate degree directly into medical school, jumping from an annual tuition of about $10,000 a year to $26,000 per year. Tuition alone, that does not include any living expenses. He's never had the chance to earn a salary. And so because of that, by the time he was just in second year medicine, he had a debt load of over $110,000. And he just said the pressure was crushing. We were able to award him with a scholarship this year for the second year in a row. We hope to support him next year as he completes his year or his degree. But then as he moves on to residency, where he will receive a modest income, but it's not enough to deal with that mountain load of debt. So there is a need from the students as well. And for those that do believe in supporting education and helping alleviate the financial strain on these students, it's a wonderful cause too. We could advance. So none of the work of the foundation would be possible without founders like Dr. Craig, but also without our volunteer board of directors, who are absolutely incredible. And while not completely representative of every jurisdiction in the province, we are working there and we are diversifying every year. About half of our directors right now are physicians, which means that we get incredible, timely information about the nuances and the culture of the healthcare system and what it's like to work there. We hear from our students, so they are incredible sources of support for us. We also have business and community leaders, though, who also share their perspectives outside the system. If we could move or advance. And that's all we have for our presentation today. But again, happy to take questions. And I really believe that this is an issue again where we all have a voice. So I would love to know your thoughts.
Thank you. I'll go to Director Fox. Do you have any comments or questions?
No, none from here. Thanks. Thanks for the presentation.
Director Pigwell?
Thank you for the presentation, and it's certainly heartening to hear the supports are in place for through this program for graduates that want to stay and people that want to stay in New Brunswick and getting to them early. And I couldn't agree with you more that getting someone at the sunrise state certainly makes a big difference versus sunsetting.
Thank you.
We'll start with you this time and go around this way. Okay.
What does Horizon Health think of this program?
Horizon Health was actually one of the founding investors of this program. So they have an endowment that's about $725,000. It allows us to support 3 large scholarships per year for students who pledge to practice anywhere in New Brunswick.
So they won't override, if they wanted to come to Ormonto, they won't step in and override them and say they're going to go someplace else?
That historically, I would say, has been the greatest challenge of this model, is that while we are a recognized member of the healthcare recruitment ecosystem, we ultimately aren't the employer. And historically, there have certainly been challenges when it comes to those regional return of service requirements. What has changed in the last 3 months, though, is that we actually signed an information sharing agreement with the province of New Brunswick, with the regional health authorities, both authorities, which allows us to share in real time our pipeline data with the province. So they know where our recipients are in their residency programs, when they're expected to finish, where they are pledged to go. And the idea is that will aid the province in a degree of sophisticated workforce planning that has never been attempted before. So that is our insurance and assurance that there is the best likelihood possible. We are doing everything in our control to ensure that these students have the best chance of returning to whether their hometowns or their pledged communities.
Well, that's positive. So I like that.
Thank you.
Okay, I guess I'm next. I do like your presentation, and I listened to that, and I think it is a good opportunity, and I think it's a great way to start a project out by supporting those students. I think education is the factor, and that's where we need to be started at the ground level. I appreciate that, and all the best on your moving forward.
Thank you very much.
No question, thank you very much.
I have a couple. Is recruiting to get people into Ormonto.
Mm-hmm.
And I like the fact that they have the scholarship. The question I have with that, and I'll use the military. You want to be a doctor, you go in the military, they pay your debt.
Mm-hmm.
They pay you while you go to school, and
you're into pension as well.
Mhm.
And when they come out, they're set, but they have to do a year and a half for every year that they paid for.
Mhm.
So if you're into 5 or 6 years in that aspect, then the person who's set up shop,
Mhm.
chances are they get married, they have kids, and they're stuck where they're at.
Mhm.
So does this work a little bit, the agreement that they come back? If I give, that you give $30,000 or something, I think it's about $7,000, I calculated, so 4 years, it's almost $30,000. When they sign, they have to come back or they give you the money back.
That's correct.
That's
So
correct,
that the agreement that they sign is a
Right.
legally binding document,
right?
and that if they do not stay, they repay the funds to allow us to award scholarships to other students.
Okay, so it's that aspect there is, but if they stay here for an amount of time, they don't have to pay any of it back?
That's right. So it's what we call a repayable award or a conditional award. So if they do not meet the conditions of the award, it defaults to a repayable award, and we have an alumni committee whose really sole or primary mandate is to ensure that those students are contacted and enter those repayment plans.
Okay. That's great, I like that. Now, here's the other question, because I've talked to 26 residents,
Mhm.
and I talked to a whole bunch of them down in, Nova Scotia. But they don't want fee for service, they wanna get salary, because we gotta pay the debt. We're trying to get them to come to Ormoc, like, build them, and they will come, like the thing. We need 4 or 5 doctors in the family medicine group, but to get the information from Horizon and transportation, everybody of what we need to build or what we need to get, it's like pulling teeth. You can't, this way, nobody wants to give up the territory, I think, is what it is between Horizon, DTI, and the other groups. If they had that information, it'd be a lot easier in order to bring in doctors that we need. Because in order to Horizon lease the building, they need so much space. So if you tell a developer you wanna build something and these 2 floors will be leased by Horizon for the medical clinic there, then you're gonna have a developer trying to build something. So that's where everybody's doing their job, trying to recruit, and you guys are paying, and you're close to the military, not that close, but you're close. I like that. But the aspect is, everybody has to work together, and right now, they're not working together. And then and then all the doctors, they become hospitalists, and they go work in the hospital, where they're gonna get their salary, instead of being a family doctor.
I empathize completely, and I would say in my experience at the New Brunswick Medical Education Foundation, we are uniquely positioned in a way to advocate, because our scholarship donors include the College of Physicians and Surgeons, the regional health authorities, the Department of Health, the province of New Brunswick, regional service commissions, and so for us, it's a matter of picking up the phone and saying, which donors do we need in the room to have a conversation? That's not saying we affect change overnight, but we do have the ability, we have a seat at the table in a way that we really haven't in the last 5 years, and that's a strength. But I do agree with you. People have historically been siloed. Recruitment efforts across the province historically have been costly, siloed, and have had varied results. But we're really working to change that. We now advocate for 318 physicians and students, and through that, we're really hoping to have a stronger voice.
Good presentation, I think.
Next.
Gave me a lot more information that I can use.
Yeah, so, this was a very encouraging news. My community has tried the same thing, but using local people, and we ran into that exact problem where they weren't going to be potentially able to stay in our area. So we stopped that funding, but we have funding available, and it would be nice to know how to reach out. This is the first time I've ever heard of your guys' community, but in your presentation, you talked about there's over 200 doctors potentially in in this program, and
Mhm.
I'm hoping that takes us from a tsunami to like a wave maybe, coming at us. And I was wondering if there's been any forecasting done to see what is the requirement of doctors for that point in time when those, funding comes, those 8 years are done. How many doctors get released into it, and how does where does that put us on our tsunami path?
Absolutely. And we actually do have some encouraging news.
Okay.
So first of all, we know that based on the provincial projections, the greatest need, which I'm sure is very clear, is family physicians by 2030, followed by anesthesiologists, general surgeons, and obstetricians. Now we can't predict what professions or what specialties these students will get into because it's based on a matching program. So even if they tell us what they're most interested in pursuing, they don't have full control over where they're going until March of their 4th year. But based on our projections based on our current retention rate, which is about 75%, or the highest retention rate of all provincial recruitment initiatives, and based on what those provincial numbers are by 2030, our pipeline as it stands just today would account for 45% of the province's projected need. And again, we have this information sharing agreement where we are the single largest provider of recruitment leads in the province's history. On January 17th, when this agreement actually goes into effect, we're in the implementation window right now, we will be handing over 200 leads to the province, and that's something we're very excited about.
Can I ask a second part of that question?
Of course.
All right, so being that the capital region is the largest region without family physicians, has there been a look at there's 200 people that are in, how many are retaining it within that capital region moving forward?
One of the reasons we're here in this room tonight is because in the last 6 months, David and I have shifted our focus to the Fredericton region, which has been historically grossly underrepresented in the New Brunswick Medical Education Foundation, both from a donor point of view, but also a student point of view. Not as many students from Fredericton were applying for these awards. So we've really grown in student applications. We know that we're reaching just about every medical student out there who's eligible right now. But that's one of the reasons why we partnered with the Fredericton Chamber of Commerce to host the Health Summit next week, is to ensure that not only our story gets told, but we've invited a panel of experts to discuss the current state of healthcare. We've invited a representative from the Department of Health to answer questions with the moderator. This will be an information session that's not just about us and our scholarships. This is far greater, looking at healthcare and what we can do that's actionable today, but also on a long-term basis to make a difference and to help address the needs in this region.
And last question, I know I'm on a timeline, but
No, actually, I'm gonna allow it tonight because this is
okay.
very important conversation down the table.
So is your funding looked at besides doctors, at nurse practitioners as well, that will look into?
It does.
Okay,
We
I'm done.
expanded our mandate officially last year to include a number of allied health professions.
And how do we get in touch with you?
I'll make sure that,
have all their contact.
Well, we have money available, so it's not just a handout, it's we're looking to participate in the action.
we'll make sure that if there is a scholarship in the future, we'll make sure we get it set up.
Perfect.
Okay, next.
No, I'm good. Thank you for your presentation.
Thank you.
Very good, thank you.
Thank you, Madam Chair. Thank you very much for your presentation. Delightful to see you again. I'm curious, have you done the financial modeling to understand the size of the necessary endowment to fill your vision for funding? What does that number
We
look
have.
like?
So the Doctors for NB campaign is getting us to that 100%. That's the mandate and the goal. And what we would need is annually an increase of about $400,000 in giving. So about $1.5 million annually would grow us to a point where we could support all eligible medical students. That does not include the nurse practitioners, nurses, pharmacists, or other programs. But that is our first priority, where we were founded by physicians. We want to grow to a point where we can support the medical students and then expand from there and build the other award portfolios. So that can come in a number of ways, whether through large endowment donations. That will help us get us there faster. We also work with donors to have what we call flow-through awards, which are essentially a term commitment for an annual scholarship. Somebody might commit, for example, $10,000 for a period of 4 or 5 years. And that allows us to increase that award capacity as well year over year.
Excellent. Have you had a chance to present this to BESCOR?
We have not.
They're the largest kind of Atlantic money manager and endowment, manager. They look after mostly. Vescor,
Where
yeah.
they located?
Carlton Street, right in downtown Fredericton, yeah. So they manage the teachers' retirement fund, a few of the city of Fredericton retirement funds and so on and so forth.
Most of the government.
Most of the government, public employees and
Yeah.
retirement funds.
UNB too.
Yeah, and they have the lowest management rates of any financial managers and so on and so forth, and are a nonprofit.
Oh,
So
thank you.
if you're looking for a partner that might be interested in this wonderful endeavor, they're fiercely loyal to the needs of New Brunswick and people that are doing good work in our province. And I know they'd be gracious hosts.
Thank you very much.
Information.
Certainly.
Thank you. Anything further?
Thank you very much. Appreciate it. Thank you very much for the presentation. It's nice to have some more positive and more encouraging healthcare discussion than what's normally about this.
Thank you.
Now, I'm gonna bring up a concern in my community.
Mhm.
We have a clinic. And the doctor that was operating it had to retire. And will not say why, and it's been left empty
Mhm.
for months on end. So how do we go about getting someone to come out and take over the practice? Perhaps you could have a doctor come 3 days, 1 week, a different doctor 2 days, and then rotate it. But how do we get on that list to bring someone to our community?
What we do is we set up a call with both myself and the head of physician recruitment, with if it's managed by Horizon Health, I imagine. Then we jump on a call and we better identify what is the position, what is the value proposition that we can then bring to our pipeline. And then we reach out and we do an analysis of our pipeline and say, who may be from the region, who has ties to the region, who has indicated they may be open to return. We screen all of our candidates for all of this information, so it's really just a data pull for us. And what we do on our end is we work to match the, whether the vacancy with the most eligible students. We reach out to the students and see if they're interested in the conversation. And basically what we found is that the Horizon Health job postings can leave something to be desired when it comes to the selling feature and why physicians may be interested in applying.
So you can be part of that process?
We are
For
part
us?
of that process.
So would you start tomorrow for me, please? I'd say tonight, but I'm gonna give the night off. But no, it's very important. I'll give you contact, cause I don't wanna go month after month, like,
No, of course, if there's anybody who may be interested in that opportunity, and again, one of the services we provide is we create a value proposition out of a template job posting. We better understand the community nuances, we may get testimonials from people in the community, and we build out a package, which is then what we share with the students to better increase the chances of uptake.
thank you so much, and we will be talking in the near future. So I'd like to thank you, Alicia, for coming in, and David for being here. Excellent presentation. Thank you very much.
Thank you very much for your time.
I just want that.
Yes, yeah. I'll take one too, please.
There's in the brochures as well, they're in the packages.
Thank you.
There's the info that gets to the office as well.
No, a great presentation, very, very good.
Great to meet everybody.
Yeah.
There was one extra one down in Germany. It's all free.
I do.
Yeah, and if you go.
That's funny.
Thank you. But I would really like to have a serious
That's what we're debating now with the program.
And if you ever get all of this call them office, they'll give you my whole. Thank you so much.
Thank you.
Thanks.
Sure.
Yeah, so,
Okay, next on the agenda is number 7, the tenders, third quarter report. There's nothing there, but it's there for your, viewing. It has to go on the agenda, so we're just waiting for our CO, John, to come back, and we're gonna go into a protest.
You can, I can send you everything from sample
You know what?
agreement to the-
Your baby can't go there now, but I think you're right, go. They don't want it.
Yeah, and the officers told.
Yeah.
Night, thank you.
Thank you.
Hold up, maybe 20.
Everybody gonna go home and watch the US election.
Well, I wake up tomorrow morning, man.
Should know on Saturday.
Polls are all.
So, I need a motion to go into closed session.
Motion's in the closed session, Dave, motion has.
Greg Erickson.
Okay, we're. Closed session, so